Okay, everybody. Really kudos to Laurel and that last panel for staying on time and doing such a nice job of recapping what was, I'm sure, an incredible amount of information. So this brings us to our closing panel, no pressure. We've designed this to be something where we have very distinct perspectives of stakeholder groups, if you will, who can sort of help us figure out what our next step should be, particularly on the policy side, but more broadly, about how to move progress here and how to improve children's behavioral health. We're still couching this, as I promised, back into thinking about funding and thinking about how to sustain funding for the things that we know work. And we still have as our, in the back of our thinking, the Affordable Care Act as some of what propelled us to look at this. But we're going to walk through a few questions with our panelists, and again, you'll appreciate that they have unique perspectives to bring to bear. So I'm going to introduce them in alphabetical order very briefly. Their bios are available, and then we'll get started with some questions and have some time for you all. Julie Beckett has just retired from being at the University of Iowa for 34 years. During her time there, she worked for the Title V program, Child Health Specialty Clinics, the University Centers on Disability and Development. She was co-founder of an organization called Family Voices and currently serves as the co-chair of the Family Partnership Network with the American Academy of Pediatrics. So Julie's daughter, Katie, was the first person to receive a Medicaid waiver for home-based services. She passed away a few years ago at the age of 34, but Julie has been an incredibly effective advocate from the family side and has learned a lot about how to improve public policies so they serve families better. Jorielle Brown is a clinical psychologist, works currently as the director of the Division of Systems Development in the Center for Substance Abuse Prevention at SAMHSA. Lieutenant Brown was recently commissioned in the U.S. Public Health Service and has held a number of posts at SAMHSA and in academia. Wilson Compton is Deputy Director of the National Institute on Drug Abuse at NIH and obviously provides scientific leadership in the development, implementation, and management of NIDA's research portfolio and assists the director. David Shern has just recently stepped down as President and CEO of Mental Health America. Has had a number of posts in both academia and in the advocacy arena and in the state policy arena, working on issues related to mental health and mental illness, and most recently has been working more on prevention and health promotion. And Terry Stancin is Professor of Pediatric Psychiatry and Psychological Sciences at Case Western Reserve. She also directs the Child and Adolescent Psychiatry and Psychology Department and is Vice Chair for Research in Psychiatry at Metro Health Medical Center. Importantly, she's also here representing the Society for Developmental and Behavioral Pediatrics as their current president. So you can see how the 5 people we have convened here are coming from slightly different perspectives on how to go from here. How they might collaborate with us, and how each of their stakeholder groups might advance progress. So our first question for the panelists, before I step down, but maybe Wilson, you could start this off, is what do you see as the greatest opportunity for promoting behavioral health in children and families that has been created or mobilized by healthcare reform?
Well, thanks very much for this opportunity to speak to the group here. It's certainly been a very important meeting addressing a topic that's been of tremendous interest at the NIH and to me personally, and particularly at the National Institute on Drug Abuse. Over the last few years, once we started recognizing the dramatic changes that were underway with the healthcare reforms, and I put an S on that because it's not just the Affordable Care Act, but it's also the Mental Health Parity Act. It's payment restructuring as part of Medicare services and as well as state and local initiatives that are producing major changes all across our country. But within these is an emphasis, I think, on 2 major themes that I find particularly exciting. that we've been bringing to various groups, whether that's the National Prevention Network to address state-level innovation, whether that's CADCA to address community coalitions and their role in implementing a change at a local level, whether that's Society for Prevention Research to help inspire researchers to write applications that we might fund at the NIH on these topics, or writing RFAs and others to inspire people in this area. But I see two major themes. One is the emphasis on primary care throughout all of these, the integration of mental health services, and the parity for payment. After all, that's going to be a major driver, is making sure that clinicians actually get paid a living wage for providing some of these services that are part of behavioral health. So one is the primary care and the emphasis on parity. The second is the systems level change. And this is a little bit newer thought for me that Jeff Levy and others have helped inspire in my mind, is that we might, when we shift to population-based payment for services, we have a very different paradigm. I mean, I'm a clinician fundamentally, so I think about doing something and getting paid for it. That's an easy model. And taking family-based interventions that we develop for schools or individuals and embedding them in primary care is a natural next step. But another approach is more paying for the good behavior game through community care organizations. That's one example that a few years ago I heard about in Ohio. Now I come to know that it's Kelly Kelleher's group that implemented that. I wasn't sure who, because I heard it from a community organization. But those are ways to think about a long-term payoff that the insurers and others will see as in their best business interests, either because it improves the healthcare in a reasonably efficient manner, or there's cost offsets. And I think there's a little bit of a trap in requiring cost offsets, but I certainly understand cost effectiveness as being a goal. And research, we're open for business. Send us your ideas.
Okay. So I'm representing primarily the Society for Developmental and Behavioral Pediatrics today. And I'd first like to say I'm a little embarrassed. I've been traveling all week, and I didn't realize that today is National Autism Awareness Day, and we were all supposed to be wearing blue. I'm looking around, not a lot of us remember to do that, and I'm not even wearing blue, and I'm representing the society that really is all about taking care of kids with autism, so I am apologizing for that, and to also just hope that you all are thinking about people with autism today. SDBP is the only society that is exclusively geared towards developmental and behavioral pediatrics. And it's what's, I think, important and unique about this society is that it is truly interdisciplinary, and it's comprised primarily of developmental behavioral pediatricians, but also a large proportion of psychologists like myself, and increasing numbers of nurse practitioners and other health professionals interested in developmental behavioral pediatrics. And so I think that the discussions that we've had yesterday and today really support the idea that the society has about team-based care, interprofessional services for children, especially children with developmental disabilities and behavior disorders. So I'm very excited about what we bring to this table around that. We also have an interest in public health, the public health approach to these problems, and I think that healthcare reform certainly is an opportunity for us to explore a public health approach to dealing with developmental and behavioral problems. Access to services is a big issue in terms of primary care, but also subspecialty care for children with developmental behavioral conditions. And so I think we need to be looking to this group to help guide those discussions as well. So I think I'm going to stop until our next question for now.
Hi, I'm Katie's mom, and I always think of Katie as being the first of the healthcare reformers in this country, because she really changed healthcare payment policy more than anything else. But beyond that, we also had to work within the systems to get them to understand how families can really be partners with them and work towards a way of implementing in a national organization like Family Voices that actually recognizes all kids with special health care needs and works to get them into services within their community. I'm very proud to say we were able to get a bill passed several years ago when there was never any new money talked about, and all of a sudden somebody came up with money for us to start family-to-family health information centers. There's one in every state and in the District of Columbia. They are managed by families. They work very closely with professionals, all professionals around families. And there's nothing about children with special health care needs necessarily in their name, because they're supposed to serve all families, not just families of kids with special health care needs, but families. And so our strong push is really early childhood education, early identification, early childhood education, all those kinds of things. Getting to healthcare reform, I think it's important to recognize that I started at the University of Iowa developing the home care monitoring program to help get kids on Katie's waiver kind of thing. And so how we did that, and we started with the Title V program, which thank God John McQueen, who was my mentor, really talked about the importance of community. And so his whole concept was that he developed clinics across the state of Iowa. They're still in existence, 14 regional clinics. They're administered out of the University of Iowa, which give you a great deal of benefit. I started in 1984 because Katie was on Medicaid because she had used up, after 3 years in the hospital, had used up a $1 million policy on Blue Cross Blue Shield. So when I became eligible as a part-time employee at the University of Iowa, they had to take Katie back. So, thank you everybody who gets well-marked Blue Cross Blue Shield. But I do want to say that it was so important to Medicaid to realize that those things can happen for families if you just allow that stuff to happen. Well, John was smart enough to recognize that families couldn't just travel to the University of Iowa to receive services, even though that was kind of the home place you could go. But rural communities, that was putting somebody in the back of an ambulance for 6 hours and sending them off, that kind of thing. We had mobile clinics for a while where we actually took people, docs, residents usually, out to the clinics for cardio or pulmonary or ortho, those kinds of things. Now we've really, we've had to grow up, but the clinics are still there. And instead of starting something new, our health home program through Medicaid is actually running through those clinics. And the person in charge of that is really is a parent. She had foster children, 22 foster children, and adopted 4 of them, all with behavioral health issues, all, and still is a single parent and still does this job incredibly well. But she's really good at knowing how to train people, set up programs that help. So the clinics run by pediatric nurse practitioners are all trained in behavioral health and how they look at both behavioral health and medical care and health care and emotional behavioral issues along with all of it, and how important that is to work within the community. The smart thing about these clinics is that the board that runs them is made up of the community. So the guy who runs the bank, the police chief, are all they're all there. So they are engaged in recognizing how important it is to serve these children and their families. And so they haven't left that out. In this new health home project, the nice part about it is that the first person a parent talks to when they call the clinic is a family, a parent of a child with special health care needs, and usually some emotional and behavioral issues as well. And it's very nice for a family to feel like they're talking to another family to begin with. They set up the appointment, they send out the referral stuff, they do all this stuff. And if they have a question, the parent is the one who follows up with them. And then once they have, it's very nice. We use telehealth because there are 22 psychiatrists in the state of Iowa, 22, and most of them are retired. So it's nice that at the University of Iowa, we have a program that allows a psychiatrist to actually sit in a little room, so there's total privacy, and he interacts with the young adult or the child, and then interacts with the family, then talks with the nurse practitioner, and they come up with a plan with the family to decide how to help, react to the issues that are at hand. So I'm going to stop there. But it's been an amazing program, and I have to tell you that there are 45 family navigators trained and certified in the state of Iowa for reimbursement.
Thanks, Julianne. Your story is just very inspiring about Katie and how one person can really make a big difference. I'm here representing a couple different perspectives today. One is the National Association of State Mental Health Program Directors, which is the organization that represents all the state mental health authorities. And Pat Shea and I and others at NASHBID have been working on trying to, in our minds, to reconceptualize what the emerging role for state mental health authorities may be in a post-ACA world where we approach universal insurance and in a world where we continue to talk about integration of whole person care. And so what we've been trying to do in part is to try to bring a strong prevention focus as a new potential role, leading behavioral health in the broadest sense in states for an evolving role of state mental health authorities. And so that's one role. The second one is the Mental Health America and the National Mental Health Association. And we're distinguished by, number one, being very old, 116-year-old organization founded by a person who had mental illness, Clifford Beers, as well as a psychologist of some note named William James and a psychiatrist named Adolf Meyer. And it was founded originally as the Committee on Mental Hygiene. And the notion there was to try to emulate the work that was going on in public hygiene that was revolutionizing health. And I talked about this just a little bit yesterday. And so Beers and James and Meyer and others really had a vision of population health that embraced prevention all the way through cure, that by its very nature talked about the things that Bill was talking about earlier in terms of principles of social justice and inclusion. Remember, Beers' experience was that he was excluded. He lost his voice when he was institutionalized, and what moved him in part to establish this national organization was to do things to make sure that dignity and voice and empowerment of individuals were central to a treatment and rehabilitation process. And that's in the DNA of Mental Health America, of our organization. So from our perspective, this is a very propitious time. And the things that Wilson was just talking about in terms of a kind of a return or a nascent kind of concentration on population health is exactly where we think we need to go. Over the last several years, as I finished up being CEO and then entered sort of project work, people always thought I was retiring, but I never really intended to do that. I mean, they're trying to get rid of me, and it was sort of a subtle way of saying it. But I started working with colleagues on this notion about what we see as this next major emerging theory of the things that importantly underlie the health of our nation. And we feel that if you look at the indicators of the health of our social capital in this country, that we have some profound areas of concern. You know, we incarcerate more people, we spend more money on health care, we have the highest rates of mental illness in the world. Our academic achievement is at the bottom of and going down of the OECD nations. We should be very, very concerned about those issues. What we feel, though, is that there is, in fact, emerging science, and in fact, it's very much good enough science that shows that we understand the antecedents for many of these problems. And those have to do with healthy child development, behavioral health development. And the data, you know, we talked about a little bit about it, Neil did yesterday, about how genetic vulnerability in combination with either resilience, either learned or inherited, plus exposure to toxic stress and trauma, literally becomes biologically embedded. And starts to set a life course trajectory that first will probably evidence itself with behavioral health issues or challenges, but then will turn into academic challenges, that then will turn into decreased socioeconomic status, kind of locking people into this sort of cycle of poverty. And the good news is we know a lot about what we can do to intervene in that process. Ultimately, I think we'll discover, and I think Neil was talking about this a little bit yesterday, that there's a common pathway that leads through vulnerability plus exposure to these behavioral health problems that ultimately results in cardiovascular disease, other inflammatory diseases, et cetera, and this will revolutionize the way we think about these interventions, because that's the common pathway through which our biggest problems from a cost perspective, chronic disease problems, are partially mediated. So what we've been trying to do is to tell that story more effectively, to advertise what we know can make a difference in terms of altering those trajectories. You know, we're lucky in that we have 20-year follow-up data on Seattle social development, probably more than that, Dave. We've got the follow-up data on the good behavior game. We've got the Triple P program with multiple trials showing. We have an armamentarium coming, from the 2009 IOM report and following along of interventions that we know can make a difference. And our challenge, as this forum is very focused on, is how we go about scaling those up. And part of our work, which fits very nicely with, I think, the sort of the rhetoric and the principles of the Affordable Care Act, is to try to figure out how to tell that story more effectively and move the political will that's going to be necessary to sort of implement what we see as the next major era in public health. And later in discussion, I think there's some other things that are happening in our environment, and Wilson's notion of reforms and information that are also going to bolster us in that effort. Okay.
Good afternoon. I am with the Substance Abuse and Mental Health Services Administration, and there we do believe that behavioral health is essential to health, prevention works, treatment is effective, and that people recover. In that vein, I do want to acknowledge that I do have two colleagues here in the audience, Gail Ritchie, who's with our Center for Mental Health Services, and Costello Green, who was on a previous panel, who's also in the Center for Substance Abuse Prevention. And I want to do that in case there are follow-up questions around any of the topics that are discussed, so that you know that we have other SAMHSA colleagues. I believe Dr. Lark Wong was here yesterday, and some of you had the opportunity to speak with her as well. In terms of the greatest opportunity for promoting behavioral health for children, youth, and families, honestly, I think it's just what we're doing right now. It brought people together to the table that weren't talking before. And the administrator of SAMHSA, Pam Hyde, believes in something called advocacy by nuisance. Every time there was conversation about health reform, and it was primarily CMS at the table, also HRSA at the table, she was pushing her way through to make sure that mental health and substance abuse were talked about at the table. So the greatest opportunity really has been to force ourselves into the conversation and out of the silos. And as kind of delving down a little bit deeper, I would really say it is an opportunity to capitalize on prevention, prevention, prevention. Prevention really is at the cross-section of primary care, mental health, and substance abuse. And in that vein, working together to improve community health. So we have a huge opportunity because there is an emphasis with this administration in particular, and what a train that's gone down the road, no matter what happens in future years, the train is gone, and there were things that are not going to be able to be changed because of this, because of the reforms that have happened. And there's a focus on prevention. If you look at the U.S. Preventative Services Task Force, the focus that is there, the priorities that have been set, clearly building healthy communities is front and center. So we need to take that opportunity to capitalize on this focus on prevention and make sure that our kids, our youth, and the families are clearly continue to stay at the table. I heard yesterday, I wasn't able to be here, about maybe not always being the nice guy. And I think that we've had some models of where that's been effective, and even some of that the out of the box thinking that really, even though we kind of snicker at it, it is a reality for what's going to continue keeping us on the train and keeping us capitalizing on the forward momentum that has started already.
Thank you all so much. It's such a wonderful start to where we can move our conversation now. So I think I'm going to combine our two other questions so that you can really take some time to think about these, which is really what needs to be done to make the priorities you've identified happen, and what can your sector do to make that happen? So let's think just, bringing us back to where we started yesterday, we really want to focus on actionable suggestions and things that we can each, take a part in making happen. So I'm going to try to take that focus here. So Wilson, you'd be starting from the, obviously the perspective of a federal funder, and then so on as we go down the line. But if you could think about what needs to happen, especially at the policy level, um, to make your priorities come to pass?
Well, of course, you're asking me about what can research do in this area and what can we at the NIH do in this area. And I think a consistent focus on systems level research will be needed, that some attention to funding studies that look at the integration of, in my particular case, drug abuse prevention and intervention services within healthcare reforms. But the secondary issue would be, I'm very keen on the whole family approach, and I was very glad to hear the approach emphasized throughout the panels here around families. And that seems to me just a setup for retooling some of our community-based or school-based family formatted interventions to implementation in medical settings. That's not a major retool. To see that they could work, and then make sure that we embed services questions in those studies. That's been a theme that Liz Robertson and my colleagues in the prevention research branch at NIDA, Harold Pearl's here, and Belinda Sims is here, and we'll still take credit for Eve Rader, even though she's now at the I don't even know the name of your institute anymore. It just changed from complementing alternative medications. So retooling the interventions is a major theme, but making sure that we think about implementation at the same time. I'm keeping it quick. So
Yeah,
we can...
right. Couple thoughts I have about that. First of all, is that what we often talk about is payment issues. How do we get paid for all these things that we want to do? And so I think that is a real struggle around how we can get paid for those services for things that are not necessarily diagnoses, prevention activities, for the work that's done by physicians that are mental health related. How can primary care providers be paid for providing all those things? So issues of payment reform and is very important. But what I really want to focus in today, I think, is on workforce, because we've talked yesterday and today about the need to have a competent workforce, and the society is very interested in how we can recruit more people in developmental behavioral pediatrics and in psychology and other fields to do this work, and how we can train them appropriately. Training new doctors is very expensive. The ability to do that in most medical settings has become increasingly difficult. For those of you that work in that setting, and you understand that we don't have as much time perhaps as we used to do the training. We aren't getting paid for that training. The health grants to support the training are much more difficult to get. It would be great to see more support coming from the federal government to support training of physicians and other behavioral health providers going forward. I think that what we can do to help that along is that we as a society can support competency guidelines. We can have activities that are educational activities that will help promote fellowships and other levels of training. MCHB has actually been very supportive of training in developmental behavioral pediatrics, so we were very grateful to those funders, but we need a lot more of that going forward. We also need to be doing a better job of recruiting a more diverse workforce. So our workforce is, for children, is mostly female and mostly white. And, that's me. But I think we need to be doing a better job of having more diversity. We need to have our workforce reflect the patients that we take care of, both in terms of diversity in all regards. So we need to do that. I also think it's important to recognize that we need more psychologists. We hear often that there are not enough child psychiatrists, but there really are not enough child psychologists either. There's probably about the same number, maybe a little bit higher number of well-trained child psychologists than child psychiatrists. And developmental pediatricians is even less. So we really, if we're going to have doctoral level providers at least participating in this care, we need to do a better job of growing that workforce. Of course, we also need to grow the workforce of community providers and other folks at all levels of training. I'm not saying that, but that's something that I think our society is committed to do, to try to enhance the training, to try to enhance and grow the workforce for people who are taking care of these kids.
Well, my comment would be around the community. It's really important to think of how we build those resources around a community setting, how those workers come out of a community, how we talk about how our kids can be a part of the workforce in the future. And I think that's really a critical piece. The one thing that I didn't tell you about is I'm also co-chairing the Family Engagement Network through the American Academy of Pediatrics. And what we've done is we came from the section on home care as a parent advisory group to them, and the board has taken it upon them to say it's important to have families at all levels of the academy. So they're supporting our 7-member executive committee, but we're just doing that to outreach to different sectors of the family population who are out there being family leaders and being a part of what goes on in communities and can help format some of that kind of information. And so networking, the primary goal here is really getting into those pediatric offices, the family practice offices, making sure that we're outreaching, talking about family advisors. And we're trying to stem that as a very important aspect of their office practice. And it's cost efficient for them because when you bring families and they're satisfied, they bring more families and you have more income coming in. And how important a family advisor is to an individual practice can be a critical piece in what they're learning about what their community needs, what their families need, what their office needs to do to help families, those kinds of things. So we're working on that with the American Academy of Pediatrics right now and very, very proud of that kind of work as well.
Well, I think that as sort of representing Mental Health America and the advocacy role, obviously, we worked very hard for many years on the parity legislation and on getting the minimum benefit carved into the Affordable Care Act, which hopefully will change everything by making mental health and substance use services a mandatory component of that. So one thing we'll continue to do is to continue to advocate at the federal level in every opportunity that we can identify. Additionally, we cover about 90% of the U.S. population in terms of our state chapters. They continue to work on the implementation of the parity bill, which is not by any stretch of the imagination a done deal. There's still a lot of work there to actually assure equitable access to care. In those regressive states that haven't expanded their Medicaid benefit, and Florida, I'm proud to say, is one of those states. Florida, we're trying to figure out how to tie that to handguns in some way so we can get through the legislature. I kid, my state. That Medicaid expansion is obviously critically important. And as Kelly and I were talking about earlier, that universal coverage really starts to change everything in terms of the overall incentive, both to keep populations healthy. And since insurance companies increasingly are less able to deselect sick people from their programs, they now have no incentives to keep populations healthy because the churn factor starts to not be as important to them because anybody can get into their plan. So I think that we need to, in that context, continue to tell the story about prevention and the importance of prevention interventions, and to think about how health insurance mechanisms might be used differently. And we're coming back to the same examples of the community care organizations in Oregon funding the good behavior game for Medicaid enrollees as well as other low-income kids. The work that Kelly's doing in nationwide in terms of the good behavior game, universal primary prevention intervention paid for with health insurance money, and that gets beyond the medical necessity criteria that has been a stopper for us, and I think it's huge. One thing that advocates have to do is they have to tell that story. They need to make sure that other states understand and other Medicaid authorities, Lindsay, understand the possibility of starting to use health insurance money to fund preventative interventions. In addition, in Washington State, they've been very clever in terms of using Medicaid funds to prescribe the PPP program to parents, to parenting programs, and have that reimbursed through Medicaid. For me, from my perspective, those financing mechanisms are huge. The other thing our advocacy organizations, I think, can do is the thing that Jose talked about yesterday about the other problem all the other entities. It's clear from my perspective, and I think that this is something that's been facilitated by healthcare reform, that it's absolutely essential that we start to think about overall societal costs and benefits of these interventions. And Kimberly and others were talking in our last session about the Washington State Institute on Public Policy. And that's a group that was created by the Washington State Legislature to advise them on their portfolio. They're the portfolio advisors. So they tell the state how they should invest their money. And they've done some rigorously peer-reviewed work monetizing the costs and benefits of a wide range of preventive and treatment interventions. And that work has had great traction in Washington State. They've taken 2,000 prison beds off their construction schedule and reallocated those funds to prevention. But it's also been picked up by the Pew and MacArthur Foundation, who are now disseminating it to a group of states, focusing, I think, initially on criminal justice. Part of our problem is because we don't have an adequate time perspective. We talked about this yesterday. We need to continue to look for relatively shorter-term benefits. And criminal justice system is so inefficient in so many ways. I think that people are going to it and decreasing readmissions or recidivism in that sector. I think advocates have a role in continuing to publicize the fact that we have strong evidence from randomized clinical trials about the cost effectiveness of these interventions from a societal perspective. So I think our job is to continue to sort of tell that story and create a compelling sense of political will this is not only the right thing to do. You know, it's this thing, Kelly's comment about playing dirty is the thing that everybody seems to remember. I don't know what that talks about. Yeah, Kelly's thing was pediatricians are too damn nice, you know? They need to play dirty. We need to really advertise the fact that we have very solid information. This is not only the right thing to do, it's in fact the smart thing to do.
I think for SAMHSA, we have two areas where we can really focus on how we would be able to help move forward. One is in the area of partnerships with our entities that will help with the translation of research and service. And this was talked about significantly in our breakout group. But clearly, we have a model of where we've been able to work with prevention scientists and those who are actually implementing prevention in the field so that it can be evaluated, it can be assessed, and then it can be, if appropriate, taken to scale. So the CPIMS model, or the Center for Prevention Implementation Methodology, which focuses on drug abuse and sexual behavior, is something that could be replicated in other topic areas for youth, for younger children, for early child development. And I think, and I'm hoping that we'll be able to persuade such type of work moving forward. It is a partnership between SAMHSA and NIDA that has been very helpful. And it's similarly also done with, how many are familiar with the SPIF model? Everyone raise your hand. No, this is not good. Okay.
The strategic prevention.
Thank you. The Strategic Prevention Framework. Does that get any more hands? Maybe a couple of nods? Maybe. All right. So again, there was a partnership with that, with NIDA and with SAMHSA to look at how states are able to actually effectively reduce things like underage drinking and prescription drug abuse. Again, those are things that exist, but we have to be able to look at how the research is actually able to make an impact and how the services that are being done will make an impact. And so we want to look at ways that we could continue to do some of that. I think we got a couple of, I think I was the only SAMHSA person in there, received a couple of urges from others. SAMHSA should do, okay, so I wrote them down and I'll be sure to communicate them. The other thing is looking at ways to be innovative around primary prevention in the healthcare setting. And I wanted to give an example of one way that we thought about doing that innovatively and have had some successes. So we have a national campaign called the Talk They Hear You campaign, and it's for caregivers and parents of youth age 9 to 15 to help them understand how to have a conversation around underage drinking. So many parents are fearful or don't understand or don't think to or don't know what to say to their youth, to their kids about underage drinking. And we're talking as early as 9 years old. Again, this is primary prevention. So we were able to get these PSAs in over 30,000 doctors' offices, just replaying by partnering with a couple of our primary care provider organizations. And this was huge because this then drove parents to understand the importance of having the conversation, of other resources that are available to them. So again, thinking of other ways in which we can do those types of partnerships and finding that they're ripe. They are actually very willing to have these types of conversations and have these types of resources available is key. So I think, again, it's helping us to think outside of the box to some of the non-traditional partners, but also where are the audiences? We know the homes, the schools, the communities. And so obviously in the doctor's offices, we want to make sure that we are infusing the messages very clearly to them.
It's very interesting. One of the things that keeps coming across, and you've all done such a wonderful job of speaking about opportunities and what you might be able to do from particular sort of stakeholder perspectives. But one of the things that comes across that I know the forum spends a lot of time thinking about is the importance of partnerships. What Samson and Ida, for example, have been able to do here is really terrific. I want to open this up to the audience in just a minute, but I wanted to see if, Wilson, you had anything you wanted to add here, since you had you went first, but a lot of things have probably raised some ideas for you.
Well, I'm really intrigued by a theme that I've heard both across this panel and with the earlier panel around what I call changing social norms, whether that's the behavioral economic approaches, or as David was talking about, finding, maybe using, keep your brain healthy as a marketing campaign. I don't know that the evening news is the right place to reach actual parents as opposed to grandparents, but the idea of using all sorts of approaches to change the demand for these services. And I think we've been thinking in terms of, we'll facilitate what clinicians do and what services can do, but an awful lot of what's provided is based on the public demanding it. We have all sorts of autism services because a bunch of family advocates got angry and upset and made change the world. And I don't know how you create that, but finding ways to create the demand from the other side is something that we'd love to learn how to measure better and how to use research to help learn how to drive that in some effective ways.
Any other really quick thoughts from our panelists before I open it up? Yeah, please.
I just have one thing to add. This whole concept of partnership is so critically important. And I think it's great when agencies partner, but it's so great just when professionals and parents partner. Dave Alexander, who is head of the Lucille Packard Foundation out in California, used to be at Blank Children's Hospital, and he still talks about the times we used to go to the Hill together and see different offices of the Iowa delegation, and how it was just this magical moment because it was a professional and a family person talking about the same thing. And so it's a really critical opportunity that people need to think about and talk about. You have to have the reality base, but then you also have to have the stats behind you. And those are the two things that work. And that's all I have to say.
So it's time for all of you to have a chance to, chat with our panelists here about future directions, what different stakeholder groups might do to collaborate with the forum, where some of our most strategic opportunities are, any thoughts about the workshop that have. We had some conversations last night, for example, that I think some of you may want to raise some points from. Don.
I'm struck with Wilson's comment about how the families with autism seem to have succeeded, but yet many of us in the room will remember what that history was, that the decades of parents asking but being blamed and considered the source of the problem. And depending on your time frame of what you look at about the change in the system of services, it would be interesting to hear. It's interesting to wonder, do we need to go through those 6 or 7 decades of abuse of parents and children getting inappropriate services, if they got any at all? Or what have we learned from that experience that puts us in better shape now so that we don't get involved in a series of decades of beating up on parents of children with mental health behavior problems? So I don't know if that shows up in your thinking about policy, about research, about person power preparation in terms of how we bring those stories to bear on the agenda.
We've done what I think is really this compelling story that's emerging about the interaction of vulnerability and sort of toxic experiences of one sort or another has a potential to reintroduce, if it's not done well, this notion of parent blaming again. And I know that, Bill Beardsley has done all this great work around parental depression, and Tony, your comments about nurturing, trying to take a strengths-based approach to this and thinking about it in terms of adequate supports and environments for people so that the parents can reach their full potential as well as the kids have healthy environments. It's an important, we're going to have to frame this well. I know the first time that I heard Vince Folletti present information at the Carter Center about the ACEs study, which was like several years ago, one of the initial reactions was, boy, that sounds like parent bashing to me again. And so there's an interesting dynamic there just in terms of how this toxicity theory works. And it's important to think about macro social contexts and about a strength-based approach to supporting people so that they can sort of maximally benefit rather than trying to find someone to blame. I don't know if that's responsive to your concern, but I think it's an important issue.
Clearly, if it were an easy answer in terms of how we shorten that cycle of social change from many generations to just a few years, all of us would be doing it. But I think that's what partly makes it an interesting question for researchers to examine. If it had an easy answer, then I wouldn't need scientists to help explore it. That's a little bit pat, but clearly we don't want it to take decades. And so learning from the experience there or the smoking cessation efforts or major social changes that, I'm seeing in the drug abuse field around the overdose issue, which went from a sort of bubbling along for 10 years interest and then just all of a sudden hit everybody, and everybody's trying to do something about it for the last 2 years. And I don't know how we create that tipping point and use that, at least that area of knowledge from behavioral economics to influence social change that we're interested in is an interesting question.
So I can't help myself since you called out Medicaid specifically, David, in your presentation, but just had one quick comment. I think there's a recognition of the importance of prevention in Medicaid, but just a comment about remembering that, Medicaid in and of itself isn't the silver bullet. It's really the agency partnership and linking those systems and those funding streams and thinking about ways to promote evidence-based prevention.
I just wanted to bring up one particular idea that Mental Health America is promoting at the moment, which is the issue of capturing cost savings within the policy. And so within the home and community-based services waiver, it says you can trade so many inpatient days in lieu, or trade home-based services in lieu of inpatient days. And so it sort of creates this like internal cost effectiveness system. And so our hope is to promote sort of the same idea of prevention, where you can trade so many outpatient or inpatient services in lieu of that prevention services, and sort of building in the cost effectiveness into the idea itself, which requires some amount of maybe ARC intervention to determine those sorts of things and standardize that. But our hope is that in the future we could create those sort of internal cost effectiveness.
I just wanted to raise a question about who's in the room one more time. And, unfortunately, I'm old enough now to know a lot of the people for more than 25 years we were talking about the other night, and it's the same people in the room in that context. And I think we have learned a lot during that time. But the challenge in my mind is that pediatric healthcare spending is 6 cents on the dollar pessimistically and 9 cents on the dollar of all healthcare and mental health dollars optimistically. And it's as we heard yesterday, budget dust in the big picture. Unless we make the linkage with adult chronic illnesses and spending and have longer term, this is irrelevant conversation for, I mean, we can keep trying unless we carve out kids and make it a separate system, which I'm all for, and that's what we're trying to do in our smaller part of the world. But we have to make a better linkage to adult quality of life and expenditures and costs to the society and workers, and the big bucket items that drive true decisions in policy in our local communities. So it's not until we talk about workers and workforce or adult healthcare costs that anybody in at least my worlds, corporate worlds, interacts.
But we have, wouldn't you agree, Kelly, that I think we have a good story to tell there.
It's getting better.
The degree to which there is this common pathway, and in fact, these are the things that are going to cause the development of these expensive chronic illnesses later, and then the burden of all the work on burden of disease. You remember how surprised we were when Chris Murray and came out and said, depression by 2010 was going to be the second most disabling condition in the world, and that was greeted by us with a fair amount of skepticism. But we now understand that these are the most chronic illnesses because they occur early. We're not effective as effective as we should or could be in treating them.
But I don't think, Dave, those are tied to employment or tied to workforce or tied to
Burden of disease is, but I'm not sure it's tied in people's thinking. I think you're absolutely right about that. We have to tell that story better.
With respect to the issue of developing a positive framing of what we're trying to achieve, I think there is a growing literature on prosociality and what that is, and the fact that most of our preventive interventions, in fact, promote prosocial behavior. The IOM report on prevention visualized the notion that we have the science to ensure that virtually every young person arrives at adulthood with the skills, interests, and health habits they need to live a productive life in caring relationships with other people. And I think that may be a framing that would be useful. Wilson mentioned the tobacco control movement, and I really do think that that's a model for what we can achieve. The beauty of the tobacco control movement was we had a specific behavior, we could measure it in populations, we could tell whether or not it was going down. When we turn to all the other things, there's a tendency to say, well, there's depression, well, there's antisocial behavior, there's academic failure, and we deal with all of those separately. But I think that if you step back and you realize that family environments and school environments are the two major venues that are causing all of these problems, then you step back and you say, if we can make those environments more nurturing, we can affect this entire range of problems. We're not set up to do that to a very great extent, but I think that that's where we need to go. The last thing I would say is that you're talking about trying to promote understanding in the larger population about this. I wrote The Nurture Effect for that reason. However, there's no sex in it.
So I wanted to pick up on Kelly's point. I don't think we're using the data that we have adequately now. In the Seattle Social Development Project, when kids were six years old, we started an intervention with their parents and their teachers, not selective, universal, helping people use something we call the social development model, simple as 5 fingers on one hand. At each stage of development, children need an opportunity for active involvement. It means a mom picks up an infant. It means sometimes when I'm in the first grade, I get to feed the gerbils, even if I'm not the smartest kid. It means that when I'm a middle schooler, they ask me, what do you think we should have on the new playground? Opportunities for involvement. Kids need the skills to be successful in their involvements. They're both social and interpersonal skills as well as cognitive skills that people need to be successful. We all know that now. And kids need to be recognized and reinforced for effort and for skillful performance. And when that happens, something that we all care about happens, which is bonding, a sense of commitment and attachment to that social unit. That was a simple-minded theory that was at the beginning of what we did starting in 1980. And we said if that happens, then when your kids get to be in the middle school years and you say, here are my standards for behavior. Actually, it starts earlier when they're in elementary school and say you need to do your homework. Kids pay attention to the standards for behavior that are offered by people they're bonded to, that they feel attached to. And if kids don't have a sense of attachment, they don't care if Mrs. Reagan says just say no, if they don't feel bonded to her. And so standards matter when you feel bonded and attached to the social units that hold those standards. We did an experiment. It started as a true randomized experiment, but through the NIH review process, it had to become a quasi-experimental study because of things we'll talk about another day. But we followed those kids. They're now 39 years old. We started when they were 6, some of them, all of them when they were 10. We did an intervention with teachers and parents based on that simple model, saying you can do a better job of parenting to help your kids become bonded and successful in life, and teaching. Now, we did this in the name of delinquency prevention and drug abuse prevention. Teachers didn't care about that, and parents didn't worry about that when their kids were 6 or 5 or they're 10. We followed those kids up. And when they were 18, we found they were less likely to be heavy alcohol users. When they were 18, they were less likely to have been engaged in violent behavior. When they're 21, they were less likely to have been involved in the criminal justice system. But what we found when they were in their 20s was that they were less likely to have mental health disorders, diagnosable DIS mental health disorders, and more likely to be economically successful, above the median compared to the control group, the comparison group. So when Kelly says we don't really have, we haven't pushed this into the real outcomes that people care about, which is economic functioning and mental health outcomes, when you look at these kinds of things, building nurturing communities of families and schools in the elementary years, and follow kids up into their 30s, you see these enduring effects. It could be better, it could be stronger, there could be bigger effects, etc. But we have this evidence, and I don't think we consistently use what we have found from longitudinal studies. And it really worries me that a lot of NIH institutes have given up on longitudinal studies. They don't care about following up intervention studies, preventive intervention studies anymore. Thanks to NIDA, we're able to follow these kids up at now age 39, and we can begin to even see effects of their participation on their own parenting and on their kids' early developmental experiences. So I think we've got to keep track of what we've been learning and use what we've been learning in this broader effort to show that this stuff matters, not just about behavioral health, but it matters about general health and success in life.
In fact, given some of those, excuse me, some of those long-term effects, Dave, and this, we also have long-term data on the good behavior game, higher high school graduation rates, higher rates of people getting to college. I mean, it's just very definitely deals with the human capital issue and sort of the health of our population. We try to say that these are like behavioral health vaccines, and just like the current controversy about vaccines aside, just like we should expect everybody to get their basic immunization before they come to school, it should be our expectation that every kid has an opportunity to participate in one of these evidence-based programs, and they will have lifelong effects. I think you're absolutely right. We have to tell that story, and we've got the data.
The comment, this is so interesting. I think that we take a life course development approach, and perhaps one of the things we should be doing is encouraging more employers to take some of their employer policies around health behaviors and extend it down to parenting and child practices. I know that my husband every year has to submit how he's taking care of how he's increasing his exercise, how he's doing all of these different things because it reduces his healthcare costs. But really they should be asking him about what his kids are doing, how his parenting practices are improving, those sorts of things. And perhaps that's another way that we can do some prevention activities through the employer.
Good afternoon. Kareem Abdullah with CATCA. I just wanted to speak for a moment. We've been talking about workforce development, and as we were doing the work here at the Forum on promoting children's cognitive, affective, and behavioral health, in terms of workforce, there seems to be, not just for this body, but a void in researchers of minorities who are doing research with minorities in their communities. And so the research that was presented earlier today, as I was just kind of going through, I also noticed that the void existed there. And my question is, Wilson, as NIDA and NIH is a huge body for the promotion of research. What's your insights on that? Are there ones that are there that we may not, that I personally, because others may, are not aware of that should be engaged in this work with us? And strategically thinking going forward, what kind of things and actions need to be taken to ensure that we increase the workforce for minority researchers to be engaged in this really critical work?
This is a major theme all across the NIH. There have been significant reports from the NIH Director's Office as well as multiple institutes. NIDA has been particularly paying attention to this with a recent council review and a series of recommendations. We've been focusing, as you would suggest, on the issue of workforce diversity, and for us, a workforce means the scientific workforce. It's a bit of an uphill battle because our statistics reflect pretty much what you see in academic centers all around the country. And so it's not, we're going to have to find a way to collaborate with the academic research centers. When we've looked at it critically, we see big drop-off between pre-doc to postdoctoral, and particularly from the postdoc to faculty level. So you have a little better representation and a broader representation of the community in the pre and postdoctoral world, but less when you get to faculty. And so that's where we're focusing our attention in terms of development of scientists at that crucial stage. So helping people with grant writing, with career development opportunities, and we hope that'll make a difference. You got to come see me in a few years to see whether it has the impact we hope, because these things do take time to shift the workforce.
I just want to add one thing to that. I've had the privilege of I was one of the founding associations when I worked for SRCD of a collaborative to enhance diversity in science, which included many of our professional associations, including APA, including AAMC, and they are alive and well and working very hard with NIH, with NSF, and with the minority caucuses in Congress on this issue. So this is an issue that's, I know near and dear to NIH and to NSF, but also to the professional associations in the different scientific disciplines and to Congress. And people are working on it really hard. And I could certainly in our, this afternoon, I can give you the contact information for that organization. Hendricks, did you have a, yeah.
Yeah, I just wanted to follow up with Karima's comment in here. I think, and I know that Jose's standing on the other side in here, as the only principal investigator for any of the centers in here for translational research that is a minority PI for that one. I think there's a strategic challenge that we have not met in our field yet. I think it includes all the issues of development and training from early stages all the way up through the other areas in here. We're very blessed that NIDA has been a supporter of diversity supplements. We think that those are a really great, important opportunity in here, brings young people in and brings them in here. But I think that we're missing this kind of gap that we still have not gotten. We've been calling it scientific equity. It's an issue that, not just the healthcare system doesn't have equity yet, but it's also that the scientific system of producing knowledge and producing workforce, scientific workforce, and partners in communities in here to really develop this next stage of work in here. The simplest idea of that is if you're going to be doing a synthesis of where the research dollars are for trying to say, do these programs work in particular communities? And you only have a representative sample of less than the proportion of the population for minority interventions. For interventions in minority communities, you're never going to be able to get the kind of precision you need for the other ones. And the NIH principle of trying to include minorities in the randomized trials is not sufficient to try to do that. So I think it's a bigger problem that we have to deal with.
Well, now that Hendricks has raised that, I have 2 points. And I'll start with the latter one. I think it's a huge travesty, the policy of including minorities in trials. And so I'll start there. And the reason for that is that we don't design the trials in a way that in which they yield any information on the impact of the intervention on minorities. And so what you do is you get some tokenism. You get a few of this and a few of that. And at the end of the day, when you analyze the data, you have nothing to say about how effective the intervention was with Hispanics or with African Americans or with Native Americans. So it's a huge travesty that we have a policy that looks good, sounds good, and actually interferes with our ability, or at least the way it's implemented and the design and implemented, interferes with our ability to derive information that's useful to our minority communities. So I wanted to follow up on Hendrik's points. Now I want go back to what I wanted to say. Hendrix is right. I'm the only PI out of 62 clinical and translational science awards who's a minority, and I should say an underserved minority group. And we have talked a lot in this forum about the multi-generational approach, about the role of communities. And we have not thought that that's also important in the development of young scientists. So the approach to the development of young scientists, it's an individual approach. It's the K Award approach, or even the R25 approach, or the T32 approach, which basically works on a scientist at a time. And I'm going to be a little self-serving and talk about an organization that I established in 2000 called the National Hispanic Science Network on Drug Abuse, which has been the only science network for health scientists in the country all these years. And that organization created a community of support, broad support for Hispanic investigators working in the drug abuse field. And it was enormously successful in generating a whole cadre of young investigators who went on to academic positions and to get NIH funding. But it has not continued to be supported because the support is going to the individual investigator, and there isn't a good understanding that you need a community to support investigators. And most minority investigators, if you're in a research university, you have some disadvantages because you're one of very few, and so you get put in every committee and every dissertation, and you teach every minority course, and so you don't get tenured, and so you need some proper mentoring for people who have gone through that. And if you're in a not in research-intensive university, you don't have the adequate environment to support you. And so having this national network of scientists, in this case it was Hispanic scientists in drug abuse, really had a huge impact because it created for young people either in research-intensive or not research-intensive university a context that protected them, that mentored them, and that gave them the skills they needed to carry out the work. Wilson, I'm looking at you.
It's a terrific organization.
Okay, I want to move us to a close and be mindful of everybody's time. So before I do that, I just want to thank this panel for doing a wonderful job of trying to wrap up some thoughts for us.